This is a case study of OCDs of the lateral femoral condyle. OCD stands for osteochondral dissecans. General information on OCDs, it's a multifactorial injury. The etiology is largely unknown. It's commonly attributed to genetic predisposition, localized degeneration of the articular cartilage, ischemia, and it just could be a combination of all these different things. So for the OCD, in regards to the lower extremity, typically occurs on the lateral distal aspect of the femoral condyles, and it affects the articular cartilage, so it's bone-on-bone articulation, which is pretty painful. And this injury typically occurs in kids and adolescents 10 to 20 years old, and precautions mainly emphasize non-weight bearing post-op for the first 3 weeks. So our patient background info, he's a 24-year-old male soccer player, and he's a referee on the weekends whenever he's not playing soccer. Mechanism of injury, he was injured Sunday, March 26th. He was playing an intramural game. He was going for a ball. A defender struck his lateral aspect of his right knee, and he dropped to the floor immediately due to pain, and he presented with acute trauma due to the collision. The patient has no family history of OCDs, and he has never had an injury to the right knee before whatsoever. The patient had radiographs taken of his right knee in the anterior, posterior, lateral, and tunnel view orientations.
Here are our SMART goals for our patient. From 0 to 2 weeks on the inactive phase, we're going to have the patient report a pain level of 4 out of 10 by 4/9/17, and then in his active range of motion, we're going to have his extension. The patient will reach 0 degrees of knee extension by 4/9, and for knee flexion, he will reach 60 degrees by 4/9 also. And then in our active phase, which is 3 to 4 weeks, the patient will perform active straight leg raises to 45 degrees of hip flexion pain-free by 4/23/17. Then the patient will perform short arc quads against gravity only to 0 degrees extension pain-free by 4/24. And our third goal for the active phase is the patient will demonstrate 90 degrees of knee flexion by 4/20/17. Next, we're going to move into the resistive phase. That's 5 to 12 weeks, and a patient will be able to ambulate with 50% partial weight bearing by 5/8, and then the patient will ambulate full weight bearing without crutches by 5/28, so 20 days later. Third goal is the patient will be able to perform weighted squats with 50% of his body weight by 6/18/2017. And our last goal for the resistive phase is the patient will be able to perform single leg stance with ball toss on an AirX pad for 3 minutes with less than 5 step-off errors by 6/26. Okay, so our fourth phase, the aggressive phase, 3 to 6 months out. Our patient will be able to perform a grade 5 out of 5 manual muscle test in all lower extremity muscle groups by 6/30/2017. And our second goal, the patient will be able to dribble a soccer ball through preset obstacles in under 20 seconds error-free by 7/10. And our third goal, the patient will be able to perform a 6-minute mile pre-injury level on the treadmill by 7/17. And our fourth and final goal is the patient will be able to successfully shoot 6 balls into the goal while moving laterally and approaching the goal by 7/20/2017. Surgical intervention versus non-surgical intervention. So our patient had a discussion with his doctor, and he has decided to take the surgical route, mainly because he's a high-level athlete who wants to play in the championship game that's about 6 months out. And with a non-surgical intervention, it calls for immobilization for up to 6 to 8 weeks, and that's not something that he wants to do. And surgical repair is highly recommended with this condition due to the fact that osteoarthritis is often the result of untreated OCDs. So the type of surgical repair that he can have is arthroscopic debridement, and what that does is get rid of the osteochondral bodies, the loose osteochondral bodies, and it is considered the gold standard for adults. So considering the patient's 24 years old, he is out of the adolescent range. And a second study done by Gudis found that 93% of patients that underwent a newer type of surgical procedure called the Oates procedure were able to return to pre-injury levels versus 52% that returned to pre-injury level that underwent microfracture.
Phase 1, the inactive phase, we're going to have our patient perform 2 different active stretches. So the first stretch is going to be a seated hamstring stretch. The patient is seated and touching the toes with his legs locked in extension, and we'll do 3 sets of these for 30 seconds. The second stretch for the inactive phase is going to be a standing quad stretch. The patient is standing and stretching the quads. We'll do 3 sets of these for about 30 seconds each. Phase 2 of the rehab protocol is the active phase, so we're working on range of motion and mobility here, and so we're going to have the patient perform a straight leg raise for 2 sets of 10, and so the legs are just extended. And for the second exercise we're going to have our patient perform will be mini squats, and he'll do 2 sets of 10 for these. And so yeah, the patient's standing shoulder width apart, and he's going to squat down to about 30 to 45 degrees of hip flexion, knee extension. We don't want him to go too low to stress any of those joints. For phase 3 of the resistive portion of the rehab protocol, our patient's going to be performing calf raises. So our patient's standing and he's going to come up onto his toes, flexing his calf muscles, and we're going to do 3 sets of 10 for those. So for the second exercise we're going to have our patient do for phase 3, he's going to do lunges, 3 sets of 10. And so the patient is going to flex the hip 90 degrees and flex the knee to 90 degrees. Don't let the hip go too far over the toe, and emphasize correct form. And for the last and final phase of the rehab protocol is the aggressive phase. We're going to have our patient perform lateral hops over an obstacle.